All right, this is part 1 for chapter 10 in your pharmacology book, so drugs for gastrointestinal and related diseases. So your GI system is the group of organs that process food and liquids. So digestion is a process that breaks down large food molecules into smaller ones that allows our body to absorb the nutrients we need from the food and drinks that we eat and drink. Absorption is the uptake of essential nutrients into the bloodstream. Your GI tract consists of your mouth, esophagus, stomach, small intestines, colon, and your rectum. The GI transit time is the time that it takes for the material that you have eaten to pass from the mouth to the anus, which is the exit point when it becomes waste. So other organs that are involved in your GI system are the salivary glands, which produce saliva. This helps lubricate food, which will make swallowing much easier, and when we chew to break down the food. It contains enzymes that begin to digest the sugars. Your gallbladder, which is actually an organ that we can live without if necessary, but your gallbladder is responsible for producing bile, which it stores the bile, which aids in the digestion of fat and cholesterol. So what happens if you are missing your gallbladder is that you do not have that production of that additional bile that helps break down the fats and the carbohydrates or the cholesterols. So individuals that eat really fat or greasy food can have diarrhea right away after they eat that. So your pancreas, there's enzymes of various secretions, so they help digest carbohydrates and fats and proteins. They also will secrete secretions that help neutralize your stomach acid. Your liver produces bile as well. So your liver makes the bile. The liver is responsible for drug metabolization, or it metabolizes drugs before they reach their target organs, which is a process called first pass effect. So gastroesophageal reflux disease, known as GERD. Symptoms of GERD include radiating or burning in the upper abdomen and chest. You can have an acid taste in your mouth, and recurrent abdominal pain. So causes, the reflux of stomach contents through an incompetent lower esophageal sphincter, and there's actually a photo on slide 7 that shows how that happens. Food and substances to avoid, so fatty foods, caffeine, citrus and spicy foods, any gas-producing foods, alcohol, and smoking all attribute to GERD. Symptom relief, so avoiding obviously those types of foods and drinks that can produce an excess of stomach acid, avoiding certain medications like ibuprofen and aspirin and other prescription drugs, stopping smoking, remaining sitting upright for at least 3 hours after you eat your meals, and then at night, if you are having issues, sleeping with your head propped up. So antacids. The antacids are kind of like the first line defense when we have GERD or stomach acid or overproduction of stomach acid. So antacids react with the hydrogen ions in the stomach, which are used to neutralize the stomach acid. So our stomach acid is very high on the pH scale in the acidic range, and so it has more hydrogen ions than it does hydroxide ions, which are responsible for items that are a base solution. So with hydrogen ions, the antacids actually help to react with that to neutralize those. Side effects of the antacids can be constipation or diarrhea, stomach pain, nausea, and vomiting. But they actually tend to work really well, and most of them, of the antacids, you're going to find as an over-the-counter item. Your histamine H2 receptor antagonists. So these are going to be things like cimetidine, which is the generic name for Tagamet, ranitidine, which is the generic name for Zantac. Now they have pulled Zantac off the market because of the cancer-causing items inside of that drug. It is probably in the works to being reformulated, but currently right now it's in a recall. Famotidine, which is Pepcid, which is what most people that were taking Zantac have switched to, so there's been kind of a shortage of Pepcid as well. But these work by binding to the H2 receptors on the stomach's gastric acid secreting cells. So it's helping to decrease as an influx of your cells from producing too much acid. Your proton pump inhibitors, known as PPI, if you look at the list of drugs, either on your drug list for your GI list or on slide 10, you're going to notice a commonality in the suffix of the names. So esomeprazole, lansoprazole, omeprazole, pantoprazole. So most of them all end with prazole, P-R-A-Z-O-L-E. So that's one way that you can identify that they're a proton pump inhibitor. So these drugs work by binding to the proton pumps in the stomach, which therefore will reduce the aid production. So you have so many proton pumps that are working within your system, within your stomach, and what these are designed to do is not shut them all off, but shut down a good amount that are overproducing the acid within the stomach. Peptic disease. So a peptic ulcer is an ulcer of the surface lesion along any part of the GI tract that is exposed to acid and the enzyme pepsid. So a gastric ulcer is a local excavation in the gastric mucosa. H. pylori, which is a bacteria, is one of the main contributing factors to gastric ulcers. A duodenal ulcer is a peptic lesion that is located in the duodenum. And your stress ulcer is a peptic ulcer which occurs in patients under stress. So either from serious illness, serious mental stresses that they're going through, and it's caused by a breakdown of the natural mucosal resistance. So on slide 11, it actually shows you the different areas. It shows you where a duodenal ulcer would be located, and then stomach ulcers within inside the stomach shows you what a healthy stomach should look like, and then ones that are currently suffering from ulcers. So H. pylori, again, is a bacteria that is one of the main contributing factors for gastric ulcers. There are pharmacological treatments or prescription drug treatments for getting rid of H. pylori, and it's typically a combination of things. So they're going to use, let's say, a combination of a PPI and antibiotics. So if you look at slide 12, it shows you the different combinations that they use. So they're using either a gastric acid secretion inhibitor or a proton pump inhibitor, and then the antibiotics, which are actually designed to destroy the H. pylori bacteria. Coating agents. So another way that we can prevent ulcers from happening, but more particularly treating them when they are occurring, is using a coating agent. So sucralfate, which is the generic name for Carafate, what it does is when there's already an ulcer in existence, it will form a protective coating over the ulcer, which will help the ulcer heal, and it will prevent any additional acids from getting into that ulcer and exacerbating it or making it worse. It's typically used to treat duodenal ulcers because of the location of where those ulcers are is difficult to get to and treat outside of using a coating agent. These should be taken on an empty stomach because ideally you don't want anything in there, so it's coating the areas that it needs to. And there is caution for patients that are in any type of renal dysfunction. Your prostaglandin E1 analog, so Cytotec, is one of those. So it replaces the protective prostaglandins that are inhibited by NSAIDs. So when we take NSAIDs, which are non-steroidal anti-inflammatory drugs, so things like aspirin, ibuprofen, Aleve, naproxen, these drugs have a higher instance of causing ulcers. So when that happens, we would use something like Cytotec to help bring back those protective prostaglandins that are inhibited by the NSAID use. So again, they're specifically used for NSAID-induced gastric ulcers. There are some side effects of these analogs, so diarrhea and abdominal pain. But the important thing to understand about this is this particular drug, Cytotec, is actually considered a hazardous agent. So anyone who is pregnant or nursing, and everyone in general should be using contact precautions, gloves, masks, that type of thing when you're handling these particular drugs. So Crohn's disease and ulcerative colitis. So ulcerative colitis is characterized by an excessive inflammation of the GI tract, which typically will cause ulcers. And it's really limited to a specific portion of the colon or the large intestine. Crohn's disease, on the other hand, is an autoimmune disease. So this is where the immune system is attacking the tissue lining within the GI tract, the entire GI tract. So this is an autoimmune disease. It's an overproduction or overstimulation of the immune system within the GI tract, and our own body's immune system is attacking the tissue lining within the GI tract. So similarities between the two, so symptoms such as diarrhea, vomiting, bloating, fatigue, abdominal pain. There are unexpected flare-ups. It can go months and months, even years without a flare-up. Sometimes it's every couple weeks, so it just depends on the body. And then there's some similarities in the treatment options. One would be corticosteroids. So they're going to use the corticosteroids not only for their anti-inflammatory properties, so it's helping reducing the inflammation, but also the immunosuppressive properties. So corticosteroids do decrease our immune response, so they can be used as immunosuppressant agents. Aminosalicylates, so a drug that two drugs you'll see commonly is mesalamine or sulfasalazine, and they work because it's thought that these modulate chemical mediators of the inflammatory response, so reducing the inflammation properties of both the ulcerative colitis and the Crohn's disease. And then a particular immunosuppressant itself, so azathioprine, which is an Imuron. And again, that's used to suppress the immune system and stop it from overfiring and attacking the tissue lining within the GI tract. Now, when you add on an immunosuppressant drug, and even high doses and long-term doses of corticosteroids, the thing that you have to be aware of is that it's decreasing the body's immune response, which makes us more prone to opportunistic infections. So they have a higher risk of getting sick, even with a common cold, because their immune response is not what it should be, because the drugs are diminishing the immune response within the body. Gallstones. So gallstones are typically pebble-like structures that can obstruct the cystic duct. Symptoms include abdominal discomfort, and I actually really don't like that they use that as an example, because I've had gallstones, I had my gallbladder removed, and I would not describe that pain as discomfort. That was extreme excruciating pain on a level of 10 out of 10 for me. I've never experienced anything like that, even outside of childbirth. So that's how painful these gallstones can get. Sweating, nausea, and vomiting. So what are the treatment options for gallstones? Most of the time when a patient presents to the emergency room, like I did with the gallstones, there's usually a lot of stones, and what happens is the pain's not happening when the stones are inside the gallbladder. It's when they are moving outside of the gallbladder into those ducts. That's where the pain happens. Very similar to kidney stones. So a couple of treatment options that they look at is how many stones you have, what are the size of the stones, and then typically surgery is kind of the first round option, just because of the level of pain that is associated with the gallstones. But if the stones are small and there's very few of them, they can use gallstone dissolution agents like ursodiol. And what ursodiol does is decreases the cholesterol content of the bile and the bile stones by reducing the secretion of cholesterol from both the liver and then the reabsorption of cholesterol within the intestines. It's used to dissolve the gallstones that are in existence there. Some side effects for patients is persistent nausea, vomiting, and abdominal pain. And one of the downfalls to using Actigol is that dissolution or dissolving of the gallstones can actually take months. So that's why typically surgery is kind of pushed to the forefront, especially if the patient is having lots of episodes of pain. Diarrhea. So diarrhea is defined as excessive, soft, or watery stool. So there's 3 categories of diarrhea. Acute diarrhea. So these would be things like contracting traveler's diarrhea when you're traveling out of the country and you drink in their water. Our water here in the United States is treated. And most countries outside of here, or I should say a lot of countries outside of here, not most, do not treat their water. So when we visit and travel to other countries, we want to make sure that we're drinking bottled water, and that also includes ice. So ice, if you were to get an iced tea or a soda, get it without the ice. Food poisoning, so that's an acute that's brought on by coming in contact with a bacteria of undercooked food or food that's been sitting out too long, and then drug induced. So antibiotics. Antibiotics is one of the most common drugs that we have acute diarrhea as a side effect. Infectious diarrhea would be things like salmonella, E. coli, protozoal infections, or the Norwalk virus or rotavirus. So these are viruses that when we say I have the stomach flu, these would be the viruses that are responsible for making us ill. Chronic diarrhea is the last category, and that would be associated with things like irritable bowel syndrome, ulcerative colitis, and then Crohn's disease. So the effects of diarrhea, the first and foremost is dehydration. So just like vomiting, if you're having excessive diarrhea, you are expelling more water through the diarrhea than your body is able to maintain, which is going to eventually lead to dehydration. Also, the impaired absorption of drugs. So if the patient is taking medications, but they have diarrhea, it's going to inhibit the absorption of the drugs that they're taking. That also includes vitamins and nutrients. Anti-motility agents are to be used in chronic disease states only. So things like irritable bowel syndrome, ulcerative colitis, and Crohn's disease. And the reason for that is, if you are taking an anti-motility agent, which is to slow down the motility of your GI tract and to help prevent the diarrhea, if you are taking that and you are having diarrhea as a result of any type of infectious agent, so a virus or a bacteria, you are putting yourself at more risk because our body is responding with the diarrhea to expel that bacteria or to expel that virus from our body. If we prevent that from happening, that bacteria or virus is going to go systemic and we're going to get very, very sick. Absorbents, so a lot of people can use Pepto-Bismol over the counter. It will act as an absorbent and has antibacterial and anti-secretory and anti-inflammatory properties. Pepto-Bismols are used for many different things, but diarrhea is one of those. Your anti-motility drugs would be Lamodal, which is the brand name for a combination drug of diphenoxylate and atropine. Lamodal is actually a scheduled drug. It is a controlled substance. These work, and then loperamide, which is Imodium, which you can find over the counter. So these slow peristalsis, which allows more water to be absorbed from the feces as the colon contents spend more time in transit. So it's slowing down the process of the diarrhea just being expelled from the body. So when it slows the peristalsis down, our body is able to absorb more of the water into our system and slowing down the time that it's taking from the bowel movement from happening immediately. Drugs for infectious diarrhea, so Giardia, which is a protozoa acquired through water, food, or person-to-person contact. Symptoms can include abdominal cramps, bloating, nausea, and watery diarrhea. traveler's diarrhea, which is acquired through food or water that has been contaminated with E. coli. Again, preventative measures include eating well-cooked foods, peeling your fruits and vegetables or washing them very well, and drinking bottled water. So drugs for infectious disease. So rifaximin is used for traveler's diarrhea. It inhibits the RNA synthesis of the virus or the bacteria. So we're going to roll here real quickly into constipation. So constipation and related GI diseases. So characteristics of constipation: infrequent bowel movements, small stool size, hard stools, feeling incomplete after a bowel evacuation. Causes: diets low in fiber, insufficient fluid intake. Some foods can cause constipation, like cheese. And then drugs such as antacids and especially opiates. So any type of pain medication that is an opiate, morphine, fentanyl, Percocets, Vicodin, any of those cause opiate-induced constipation, which is severe. It happens very quickly. So all of our patients that are on long-term opiate use, we should be looking to make sure that they also have an order for a stimulant laxative. Okay. Treatment. So non-drug treatment would be adding fiber, increasing your fiber intake, getting regular exercise, and drinking plenty of fluid. So water is essential. Okay. Laxatives can relieve constipation. They should only be used on a short-term basis. And then you can use either suppositories or enemas, which are also available over the counter for a rapid effect. So let's say it's been quite a few days since you've been able to use the restroom. By this point, you're feeling very uncomfortable. There's a lot of abdominal pain. You can use suppositories or enemas, which are administered directly into the rectum for a very rapid effect. So that right there, we're going to pause. So we finished up on slide 28.